Okay, I'm gonna try to cover all of like the heart stuff, including the vessels, the small parts, and all of the different like atria and ventricles and whatever. And then from there, the way that the lungs are shaped and the impressions that they have will start to make sense. And then we'll do some like mediastinums, so like the superior mediastinum, and then the three separate inferiors, so anterior, middle, and posterior. And then we'll do some cranial nerve stuff at the end for neuro. So when we're talking about the heart, remember A is for arteries, and then A is for away. So anytime blood is going away from the heart, it's through arteries. Anytime blood is going towards the heart, it's through veins. This is specific to the heart though, because if you think about the lungs, for example, when blood is going away from the heart, it's going away through arteries. But for the lungs, blood is coming towards the lungs through arteries, and then away from the lungs through veins, towards the heart through veins. And same thing with the rest of the body. So this is specifically for the heart only. So A for away. So the way blood comes towards the heart is through your inferior and superior vena cavas. Inferior is going to drain everything from below your head, neck, and arm. So everything from the lower part of the body is going to go through your inferior vena cava all the way into your right atrium. Now, the superior vena cava is split into a right brachiocephalic vein and a left brachiocephalic vein. The brachiocephalic vein, so brachio means arm, cephalic means like head, neck. So the brachial part is your subclavian vein. So that's the one that, remember, is your axillary, and then your cephalic comes from the outside, and then eventually at the first rib becomes your subclavian. That becomes your right brachiocephalic vein. So left would be the same thing. You'd have your subclavian going this way, and then in both cases, what drains the head and neck is your internal jugular vein, or IJV. Those two form your brachiocephalics on both sides, and then these combine and drain into your superior vena cava. Now, arteries are different. So off of your aorta, you have three things. These two branches are actually going to go to the left side. So remember, this is anatomical position. So imagine you're looking at a patient who's facing you. So this entire part is the left side. This entire part is the right side. So this right here is going to become your left subclavian artery. So let me change the color. So left subclavian artery. This is going to be your left common carotid artery. So remember when we were talking about the interosseous artery, how it comes off of your ulnar artery? It's called common interosseous artery first, and anytime you see the word common, it's going to split into two things. So in that case, it's split into anterior and posterior interosseous arteries. Here, your common carotid artery becomes internal carotid artery and external carotid artery. Sorry for all the abbreviations. And then obviously these are both left. So left internal and left external. These come straight off of your aorta. The other side, this thing right here, it's big. You can kind of tell that it's bigger than these two. This is actually called a brachiocephalic trunk. T for trunk. This splits into your right subclavian artery and your right common carotid artery, which then would become your right internal carotid artery and right external carotid artery. So what I'm trying to say here is that with the veins, whatever happens on the right side happens on the left side. So your subclavian and your internal jugular veins combine, form your brachiocephalic veins. That happens both on the left side and on the right side. Those join together and drain into your superior vena cava. From the aorta, you only have 3 branches coming out. So 2 of them directly become your left subclavian and your left common carotid artery. On the right side, it's actually a trunk that then splits into your right subclavian and your right common carotid. So arteries are kind of different from veins in this case. Now, all of the blood that's coming from the rest of your body is going to end up in the right atrium, whether it's from the top part going down or from the bottom part going up. Your right atrium has a bunch of like holes inside of it to allow blood in. The 3 main holes are this for the superior vena cava, this for your inferior vena cava, and then you have a small hole. You can't really see it here. We'll see it on like the actual donor pictures, but you'll have an opening for the coronary sinus. So opening for coronary sinus. So the way that the heart brings blood in from the rest of the body and then gives it up again, the heart also needs its own blood supply. So the coronary sinus is what brings blood back that's supplying just the heart. And we'll see that as well. So let me clean this up a little bit so we can look at just the heart. There had to be a more efficient way to do this, but whatever. Okay. So blood, again, let's do black. So blood is pooling in from the superior vena cava, from the inferior vena cava, from the coronary sinus in here, ends up in your right atrium. Now, from the right atrium, it's going to go down to your right ventricle. Over here, you have a valve. This valve will only open in diastole, or when your heart is filling. So think of systole as when blood is leaving your heart, and diastole as when blood is filling within the heart. So this is open during diastole. And then obviously the opposite would be true. So it would be closed during systole. So during diastole, we're filling our heart with blood. The right atrium, blood will flow into the right ventricle. This is called a tricuspid valve because it has 3 cusps. On the left side, it's called mitral or bicuspid. The way I remember it is the word right has 1 more letter than left. So it has 1 more cusp in the valve. I don't know if that helps. Another way to kind of also remember this is when you're talking about lungs, your right lung has 3 lobes and your left lung has 2 lobes. So if you remember that, you can remember how many cusps are in the valve. So right atrium blood flows to right ventricle. Now, this is deoxygenated blood because this blood has drained from the rest of your body. So when blood leaves the heart and goes to every part of your body, it's giving up oxygen. So by the time it comes back, it's like depleted of oxygen. So where we get the oxygen from is from our lungs, because that's where we breathe it in. So from the right ventricle, blood is going to shoot out through this pulmonary trunk. Anytime you see the word pulmonary, we're talking about lungs. So from the pulmonary trunk, we're going to have a left pulmonary artery that'll go to the left lung. And then on the other side, you can't see behind the aorta, you're going to have a right pulmonary artery. So one artery for each side, which is different than the veins. As you can see here, there's 2 left pulmonary veins, but 1 left pulmonary artery. So, blood leaves from the right ventricle, goes through the pulmonary trunk. There's this thing called a conus arteriosus. I don't know how much or how specific he wants us to be with this, because they're treating us like we're like cardiology residents, but this conus arteriosus is here to ensure that blood flows properly from the right ventricle to the pulmonary trunk and it doesn't backflow. So the valve that it goes through is your pulmonary valve. That's easy to remember. Pulmonary valve and your pulmonary trunk. So your tricuspid and your bicuspid valves are called AV valves. That's easy to remember because AV, atrioventricular. They are literally between right atrium, right ventricle, left atrium, left ventricle, so atrioventricular valves. Your other valves, your pulmonary valve and your, where's the aortic valve? Right here, aortic valve. These are called semilunar valves. They are literally like moon-shaped. So that's where the word lunar comes from. So your semilunar valves will open and close together, and then your AV valves will open and close together. So during diastole, your AV valves are open because your heart is filling, and your semilunar valves are both closed. During systole, AV valves close, semilunar valves open, and blood leaves the heart, whether it's going to the rest of your body through the aorta or to your lungs through the pulmonary trunk. So let me clean this up again. Okay, so blood started at the right atrium, went down to the right ventricle, now through the pulmonary trunk, through the left pulmonary artery and right pulmonary artery. Not this red thing, it's actually your aorta. It's the thing behind it. Blood goes to the lungs, it gets oxygenated there. It comes back to the heart through these pulmonary veins. So you have 2 left pulmonary veins, and then you can't see them, but on the other side, you'll have 2 right pulmonary veins. So 4 total. Now blood came back from the lungs, so this is oxygenated blood. So the left atrium is technically the first part of the heart that gets the oxygenated blood. From the left atrium now, it goes through this bicuspid or mitral valve to the left ventricle, and then from the left ventricle it goes out through the aorta, and then this is when it goes through your right brachiocephalic trunk, right common carotid artery, left common carotid artery, left subclavian artery, and then to the rest of your body. Now, if you notice something, this left ventricle is way thicker than your right ventricle. That's because your left ventricle has to pump blood through the literal biggest artery in your body, which is your aorta. It has to pump blood to the rest of your body, so that's why it's much thicker. Even though it only has 2 valves in the bicuspid or mitral valve, the valves are much thicker because they have to handle all that pressure. The papillary muscles, which we will talk about, are much thicker. Everything in here has to be thicker to handle that amount of blood. So, in the ventricles, you have something called trabeculae carneae. These are just muscles that help to ensure like proper contraction, making sure that when the valves close, nothing is bulging back into the valve, because that would affect the amount of blood that's entering the right ventricle, or both right and left ventricle. So these are just muscles that help. In your atria, you actually have muscles called pectinate muscles, which play a similar role. Now, inside your right atrium, you have this. So anytime you want to orient the heart, This right here, we call the apex. This is your left ventricle, always. So anytime you're looking at the heart, this thing that's curving is your left ventricle, because this is literally how the heart sits in our body, which is why when you have two lungs that are around here and around here, they don't just sit flat. These things cause like impressions in them. So this vena cava would cause an impression here. The right side of the heart would cause an impression here. On the left side, you get a big impression here. So that's where the impression on the lungs come from. So this is left ventricle, which would make this right ventricle, which would make this your right atrium. And then up here, more so there, would be your left atrium. You can't really see it because it's more curved. But anytime you see 4 pulmonary vessels, specifically veins, in an atria, that has to be your left atrium, because those are the ones that are coming back from the lungs. So in your right atrium, you have a few things. This thing right here that they're pointing into is actually the opening of the coronary sinus. So remember, we said there are 3 main openings. It's this right here. It's this, which drains your superior vena cava, and it's that there, which drains your inferior vena cava. Now, you have a little divot right here. So it's not a hole, it's just a divot, so we call it a fossa. It's a fossa ovalis. This used to be a let me use the color black. This used to be a foramen ovale. Anytime you see the word foramen, that means a hole. So that used to be a hole. The reason for that is actually embryologically, before like we're born, our lungs aren't very functional. So the oxygen we get is actually from the placenta. So if you think about it, there's no need for us to take this entire pathway from right atrium to right ventricle, through the pulmonary trunk, to the lungs, to get oxygenated, to come back, because our lungs aren't even functional. So instead of doing all of that stuff, there used to be a hole right here that takes blood from the right atrium directly into the left atrium, so that it could go down to the left ventricle and then go to the aorta. So that's why there's that little divot, is because it closed up over time after we were born, because you don't want that anymore, because our lungs became functional. You also have something called a ductus arteriosus. This is between your aortic and pulmonary trunk. So your aorta and your pulmonary trunk. Again, we don't need blood to go to the lungs because they're non-functional before we're born. So it would skip so after right atrium, some of the blood obviously can go to the right ventricle, and then when it goes to the pulmonary trunk, a little hole in between would take it directly to the aorta, so it can go to the rest of the body, so it can skip the lungs part. Again, this eventually becomes a ligament in adults. So it's no longer an opening or a connection between them, it's just a ligament, it's just there. But the reason it was there is so that blood can efficiently move throughout our body without having to go to the lungs, which aren't even functional at that time. So those are the main parts of the right atrium. Now, we also have, get rid of this. We also have these things in the right atrium called crista terminalis and pectinate muscles. So remember when we were talking about the ventricles and how they have this thing called trabeculae carneae, to kind of just make sure that everything moves smoothly along those ventricles, like when they're contracting and everything. These play a similar role. The pectinate muscles actually come from the crista terminalis, all they do is just like separate smooth from like hard muscle in the atrium. But again, they're just there to kind of make sure that the atria on both sides are doing their jobs. Now, in the ventricles, we have these things called, so the highlighted ones are called papillary muscles. And then these highlighted things that look like cords are your chordae tendineae. So again, we're looking at the right ventricle, so we're going to have 3. When we're looking at the left ventricle, here you're going to have 2. Because the amount of papillary muscles that are connecting to your cusps in the valve through the chordae tendineae have to match. So if I have 2 cusps and then the cords are connecting to those cusps, 2 papillary muscles, cords connect to 2 cusps. On the right side, it'll be 3 papillary muscles that connect to 3 cusps because it's tricuspid, and the left is bicuspid. So these things, the papillary muscles, the chordae tendineae, and the cusps that are all connected, they all ensure that there's proper valve closure during diastole. So during diastole, they make sure the valve's open properly. During systole, they make sure the valve is closed properly because, again, these are the AV valves, which open during diastole and close during systole. They also make sure that none of these bulge back into the right atrium because, again, that would affect valve closure and the amount of blood flow would not be normal. Okay, and then this thing right here is called a septomarginal trabecula. She also called this a moderator band. So this just connects your interventricular septum. So this is right ventricle, left ventricle. Inter means between, so interventricular septum. Between your right atria and left atria, right in between there, you have an interatrial septum. So this moderator band not only attaches like your interventricular septum to your papillary muscles that will hold on to your cusps through the chordae tendineae, but they also play a role in like actual contraction. They take like electrical impulses and they make sure that the ventricle is contracting properly during systole because that's when it pushes blood out of the heart to the pulmonary trunk. Okay, now imagine you're trying to fit this heart that's shaped like this in between your lungs. So this right here is actually kind of like the shape of the heart, which is why the lungs have this shape, because they have impressions, indentations, curves, and all that stuff that has to do with the shape of the heart. So when you're looking at the lungs, there are 3 main surfaces, and they're kind of easy to understand because the one facing your diaphragm is your diaphragmatic surface. The one that is right below your ribs, remember anything ribs related, is costal surface. And the one on the inside facing your heart, so this and then this there, are your medial surface. And then obviously each lung has its own. So right lung has medial, costal, and diaphragmatic surface, and then left lung has the same. And then remember, your right lung has 3 lobes. Your left lung has... So you can kind of see them over here, but this is your superior. Let me use a different color. This is your superior lobe, and this is your superior lobe. This is your inferior lobe, and this is your inferior lobe. Now, since the right one has 3 lobes, then this right here is your middle lobe. We don't have an extra line or fissure on the right side because if you look at this and this, you can clearly see where the separation is between the lobes on the right side. But on the left side, the only one we have is this thing right here. So look at the actual shape of them. It's not straight, it's more oblique. So this is your left oblique fissure, or oblique fissure of left lung. The one that's also curving down here is your right oblique fissure. The one that's more like straight, kind of running horizontal, so let me use red. This is your horizontal fissure, and this is only in the right lung. So horizontal fissure would separate your superior lobe from your middle lobe. Your right oblique fissure separates both your superior from your inferior and your middle from your inferior. So the oblique fissure on the right separates the inferior from both, because here it separates inferior from middle, but then also here it separates inferior from superior. So it does two things. The middle lobe, the horizontal fissure would just separate superior from middle. On the left side, all we have is that oblique fissure, so all it does is separate your superior from your inferior lobe. Now, there's a part of the left lung that's technically like the middle lobe, but it has a unique name, and it's this part right here, this thing right here. So you can see that the left lung doesn't have something that sticks out like this. This is called a lingula. It literally looks like a tongue, so they call it lingula. So that's kind of like your middle lobe of the left lung, but there's only two actual lobes. Now, these are the surfaces and the different lobes and fissures. Lungs also have borders. So when you're talking about the border of a lung, this entire bottom part going around, where we can't really see it because this is technically anterior, but is your inferior border. So you would also have on the left side going like more in, like behind this, which you can't see. That's also your inferior border. Your posterior, so then you have an anterior and a posterior. Your anterior is just this entire thing right here. That's your anterior border. And then posterior border would be the one behind. So if it kind of goes through behind all the way. Posterior on the right would be this thing. Anterior on the right would be this thing. So when you're looking at a lung, the anterior border is literally anterior. Posterior border is behind, and then inferior border is the bottom. Those are different than surfaces. Surfaces are your diaphragmatic, medial, and costal. Borders are anterior, posterior, and inferior. Okay. Now, this is what a donor lung looks like. This is the entire left lung. So, this thing right here would be your lingula. This thing right here is like a cardiac notch, which is like the impression, the bend, the dent in the lung because of this heart. Specifically, the left ventricle causes this dent over there. If you look at a deeper cut, here you can start to see the fissures. So this is your horizontal, this is your oblique. So this is superior, middle, inferior. This is your oblique. It curves more, you can't really see it, but superior and inferior. Now, in the other one, this isn't really a good cut, but so this is your trachea, because you can see that the trachea bifurcates, and then you're going to have each side going into your lungs, because when you inhale oxygen, they go into your lungs. So where it bifurcates is actually called the carina. C-A-R-I-N-A. Okay. Now, imagine trying to fit this heart in between here. If we want to see the actual impressions or the curves inside the lung, you have to see it inside. So you have to look through the medial surfaces from the inside. So this picture right here does that. It turns the lungs, so we're looking at them through the this is the middle of the lung. This is the anterior, this is the posterior. So we're looking at it as if the heart is looking to its right and its left. So this is the right lung. So imagine the heart is looking to the right. On the right side of the heart, so this side, this is where we have our vena cava. Now on the left side of the heart, this is where the aorta eventually arches. So when you're looking at the lung impressions, on the right side of the heart is where you can see a groove for the superior vena cava, because the superior vena cava is on the right side. You also have something called an azygous vein. I have something towards the end that shows it a little bit more, but the azygous vein is a huge vein that drains into the superior vena cava. The way it drains into it is it actually curves around and then drains into the superior vena cava. So you can actually see this curve. The 3 or really 4 main curves that you can see on the right lung are this superior vena cava, this azygous vein that goes into your superior vena cava, the esophagus, and then this cardiac impression. This cardiac impression is really just like right atrium with a little bit of like right ventricle, because the heart is curved, so it's more right atrium than it is right ventricle. But on the left lung, this big thing is all left ventricle, because that's the part that's curved that sticks into the lung. So this is all left ventricle. On the other side, it's more like right atrium and a little bit of right ventricle. Now, on the left side, this is where you also have a groove for your esophagus, but this is where you get not only the aortic arch, but the aorta that drops after. So your heart has the aorta that comes out of it, and then we have your brachus trunk, left subclavian, and then it arches, and then it descends. It's called a descending aorta, or because now it's in like your thoracic region, it's called thoracic aorta. So it's either descending or thoracic aorta. So the key things that you can see on the left side of the heart are the big cardiac impression, the aortic arch, and your descending aorta. Esophagus you can see on both. On the right side, you'll see the superior vena cava and then the azygous vein. So the curve differences, here superior vena cava, azygous vein, esophagus. Here it's aortic arch, descending aorta or thoracic aorta, and then you also get esophagus in there. These things right here in the middle are your vessels. So these are your left pulmonary veins. I put VS for veins because there's 2 of them. So these red ones are your right pulmonary veins. And remember, they make them red because this is oxygenated blood. This is blood that has finished what it had to do in the lungs, and now it's going towards the heart. The blood that went from the heart to the lungs, remember, away from the heart is arteries, is actually this thing right here. This blue one is your right pulmonary artery. This blue is your left pulmonary artery. The white stuff is just the stuff that comes off your trachea, like your actual bronchus, your right and left bronchus. So the blue and red, right pulmonary artery, left pulmonary artery, only one of them. So 1. And then pulmonary veins, you have 2 of each. And then, I also should probably mention this, but you can also see an impression on the vena cava. It makes sense. If your heart is here in the middle, lower is going to be your inferior vena cava, higher is going to be your superior vena cava. Okay. Now, we talked about how the heart gives blood to the rest of the body. Now, we talk about the actual blood supply for the heart itself. So, off of your, so this is your aorta right here, right? And the way you can kind of tell is if this is right atrium, this is right ventricle. From your right ventricle, it's going to go up through your pulmonary trunk because it has to go to your lungs first. And then it goes to your lungs, comes back to left atrium, left ventricle, up through your aorta. So anything curving this way from the right ventricle. So if you literally put your finger in a donor's heart through the pulmonary trunk, it would go to the right ventricle. So off of the aorta, you have a right coronary artery. You also have a left one, but you would have to cut the pulmonary trunk to see it. So if you go down here, this is your right coronary artery, this red one right here. And then if we cut this pulmonary trunk, you can see the left coronary artery. These are both coming off of your aorta. So these are going to supply blood to the heart, whether it's the ventricles or the atria, depending on where they are. So you can tell here that this is going to supply both your right atrium and right ventricle. It gives off branches that'll supply other parts of the heart. So your left coronary artery will give off a circumflex artery, and then it'll give off this key artery called left anterior descending, or LAD artery. You can also call it an anterior interventricular artery because this is your left ventricle and this is your right ventricle. So it's literally in the interventricular septum it runs through. So the artery is called left anterior descending artery. The vein is called great cardiac vein. So this thing right here is your great cardiac vein. The artery that runs there would be your LAD. So the blue one is your great cardiac vein. The actual artery itself is your LAD, or left anterior descending, or anterior interventricular artery. You can see here you have something called a coronary sulcus. So now we're on the back of the heart, and the way you can tell is, remember these four things? So these are actually your pulmonary veins that drain into your left atrium. So this is left atrium right here. So now we're looking at the back of the heart. Back of the heart, this entire thing is called a coronary sinus. A sinus is just some big thing that drains. So it's where your veins will drain and then go into your right atrium, where, remember, we saw the opening of the coronary sinus. Right here. This opening of the coronary sinus is where the blood that's circulating just around the heart itself will drain into. So this is the coronary sinus. This right here is your great cardiac vein, because it'll go around here and then towards the left atrium side. So if we turned it, it's coming around like this and draining into your coronary sulcus, or sorry, coronary sinus. This smaller vein right here is your small cardiac vein. So smaller one going around, so you can actually kind of see it right here. This is your small cardiac vein. This entire hole, or like this entire like space between your right atrium and your right ventricle, is called a coronary sulcus. So remember when we were doing neuro stuff? Between your frontal lobe and your parietal lobe, you had a central sulcus. It was literally like a divot, something that separated them. So this entire thing right here is your coronary sulcus. It houses, or it fits in it, your right coronary artery, your left coronary artery. And if you keep following it around, your coronary sinus, if you keep following it around the heart. So this smaller vein right here is your small cardiac vein. This bigger one is your great cardiac vein. Now, you have smaller ones around here. I don't know if she really wants us to know these, but these are called marginal, and then either artery or vein. If it's something that's more like this, where like you can kind of like squeeze it, it's flatter, these are veins. If it's something like this, where it's thicker, these are arteries. So you can kind of tell here, this is the vein, marginal vein, and then the outside would be the marginal arteries. So you have big coronary sinus, great cardiac vein, small cardiac vein, and the one in the middle is your middle cardiac vein. So the main veins are great cardiac vein, small cardiac vein, middle cardiac vein. All of those drain into your coronary sinus, which drains into your right atrium. So again, in your right atrium, you have three main openings. You have the superior vena cava, which brings in blood from your head, neck, and arms. You have the inferior vena cava, which brings in blood from everything else, lower part of your body. And then the coronary sinus is the blood that's just giving the blood that was circulating around the heart, that was making sure that blood gets to your right atrium, your right ventricle, your left atrium, your left ventricle, to ensure that the heart is pumping properly. That drains into the coronary sinus, and all of that blood pools from all these locations into your right atrium. You have something called an anterior cardiac vein. I don't know if we need to know this, but what's unique about these is these are the only veins that drain straight into the right atrium. So all of the other veins that we talked about, the great cardiac vein, the small cardiac vein, the middle cardiac vein, they drain into your coronary sinus that drains into your right atrium. These anterior cardiac veins, they bring blood from your right ventricle. Guys, using the same colors. So they bring blood from your right ventricle directly into your right atrium. So they don't have to go through this whole process of like going around the heart or through the sulcus or anything like that. It's just a direct process with these. Okay, anything else on this side? Small cardiac veins. Okay, now this is, so the main veins we did were the small, great, and middle cardiac veins that drain into the coronary sinus, and then we talked about the marginal arteries and veins a little bit. Now for the arteries, so we said your right and left coronary arteries come from your aorta. So this is your aorta, right coronary artery, left coronary artery. And then your left will give off the circumflex, and then these are the marginal arteries that we just saw up here. This thing right here, going down like your left ventricle. The main artery going down your interventricular is your anterior interventricular, or your LAD. Remember, this artery runs with your great cardiac vein. And then on the right side, we have the right coronary artery. It also has a marginal branch, and you can just kind of see like where the arteries go is what they supply. So this right coronary artery would supply the right atrium and right ventricle. This right marginal artery can only supply the left ventricle because that's all it runs across. And then this interventricular one, this big one, would actually supply right ventricle, and left atrium because it runs through all. And then this is the back side. So this is a posterior view. And again, you can tell this is the anterior view because everything is going, so the descending part of the aorta is going away from us. Over here, it's coming towards us. Also, remember what we said, when you can see these, you're at the left atrium, so now we're at the back of the heart. So here is your left ventricle, and then technically right ventricle on this. Actually, sorry. This is technically, because we flipped the heart, this is technically right ventricle. Because you can see your vena cava. So this over here is right atrium, right ventricle. This big thing right here is left atrium and the left ventricle. But this is still an interventricular septum because it separates your ventricles on the backside. So the artery, so your right coronary artery now is coming down this way, whereas here it was going in this direction. So that gives a posterior interventricular branch, or a posterior descending artery. So same thing like the other side. And I think that's it for the arteries. Yes, okay. So now let's talk about mediastinums. So this right here, well, they have it labeled, is your sternal angle. So a bunch of things happen at your sternal angle. This is what we use to differentiate what is a superior mediastinum versus an inferior mediastinum. This entire bottom part is all inferior. Everything above the sternal angle level, all the way up to T1, is going to be superior. Everything below the sternal angle is going to be inferior. Now, your inferior is separated into your anterior, middle, and posterior mediastinums. Your anterior goes down to your diaphragm. Your middle also goes down to your diaphragm. And then your posterior goes all the way down, but your diaphragm is lower now, so goes down to T12. It's around like T5 to T12. Something quick about the diaphragm. Okay. So, if you look at the way the lung is shaped, your diaphragm, when it's rested, is actually like this, which is weird to think about, because when it's contracted, it's actually just flat. When we breathe in, your lungs want to expand, so they're going to push this diaphragm down. So this would be your diaphragm, and these would be your lungs, fully inflated. So this is when diaphragm is contracted. This is your diaphragm at rest. For the diaphragm, it's actually controlled by the phrenic nerve that runs all the way from your neck area all the way down to your diaphragm. An easy way to remember that it controls your diaphragm is phrenic has PHR and diaphragm has PHR in it. To remember the nerve roots, there's this thing, C3, C4, C5 keep the diaphragm alive. So 5 and alive rhyme. So C3, C4, C5 keep the diaphragm alive, and that's talking about your phrenic nerve. The nerve roots of it are C3, C4, C5, and it controls your diaphragm. It helps it contract and expand. So yeah, diaphragm at rest is really like this, and then contracted when you breathe in, it's actually flat, which is weird to think about. Okay, back to mediastinums. So, superior mediastinum, everything above the sternal angle. So from the manubrium all the way to T1. You have a thymus. So thymus is something that you'll find in infants and children, but as we grow older, that just turns into fat. So there's literally it just kind of deteriorates. So it's more prominent in infants, and it actually goes down to the anterior in infants and children, whereas in adults you don't see it that low because it's deteriorating. At the sternal angle, a few things happen. So this is your aorta right here. Above the sternal angle is where you'll get your arch. And then after that, in the posterior mediastinum, it descends and becomes like your thoracic aorta. Or when it's lower here, it's like your abdominal aorta. So, at the sternal angle is where your ascending aorta and then technically descending aorta will split. So over here ascends, over here descends. So that's two splits that happen at the sternal angle. Another thing that happens is you get tracheal bifurcation. So this is your trachea going straight down, and then it splits into a left and a right main bronchus that go into your lung. That also happens at the sternal angle. Another thing that happens at the sternal angle, and we'll see that later, is your thoracic duct actually crosses across at the sternal angle. So a bunch of things happen at the sternal angle, so we use it to kind of differentiate the mediastinums. Again, this is at the second rib, technically. So, superior mediastinum, we said you have your thymus, you have the arch of the aorta. If you have the arch of the aorta, then you obviously have the things that come off of it. So you have your brachiocephalic trunks, your left subclavian artery, left common carotid artery, and your right, technically, it's the only one, so we just call it brachiocephalic trunk. Again, we're above the sternal angle, so now you also have your superior vena cava. And then you have, if you have your superior vena cava there, then you're going to have both of your brachiocephalic veins because you have a left and a right brachiocephalic vein. So all of this is above the sternal angle, so we're in the superior mediastinum. You have your trachea, which is what we talked about because it doesn't bifurcate until the sternal angle. So above the sternal angle, it's just the trachea. You have your esophagus. Your esophagus really runs through both the superior and the inferior because it goes all the way. Sorry, that is your esophagus. The other one's your descending aorta. So esophagus is both in superior and posterior. And then you have a phrenic nerve, which is the one we just talked about, that goes to your diaphragm. And then your vagus nerve. This is your 10th cranial nerve. This does parasympathetic stimulation. It actually releases like acetylcholine to your heart to like slow down the heart. So for parasympathetics, it gives off a branch called a recurrent laryngeal nerve. So let's quickly go over how the vagus nerve kind of travels. So this is your right vagus nerve. When it gives off the right recurrent laryngeal, it happens right at the right subclavian artery. Whereas on the left side, you have your left vagus nerve, which is this whole thing. But your recurrent laryngeal on the left is actually this thing. So if you follow your vagus nerve here, the way you get to your recurrent laryngeal is you literally go around the arch of the aorta. So anytime you have like a surgery or something in this area, this nerve could easily be damaged. And this has to do with like your voice. So if after surgery, like you're not talking the same way, or now you have like hoarseness in your voice, it's because this was damaged during surgery. So the recurrent laryngeal nerve on the right side goes right around the right subclavian artery. On the left side, it actually goes around the arch of aorta. So that's your vagus and your recurrent laryngeal. And then you have your thoracic duct as well. Your thoracic duct drains all parts of your body except this part right here. So it's literally like more than like 75% of your body. This part right here is actually drained by your right lymphatic duct. And then the way your thoracic duct actually goes up like this, and then it crosses here. So if you think about it, if this is your superior vena cava, then where it's crossing is around your sternal angle, which is why we said the sternal angle is so important, because it does a bunch of things. Your thoracic duct actually also goes through your diaphragm. Your cava also does as well, but they don't show it over here. And then since we're talking about all these things, we might as well go to the azygous vein. So this entire thing is your azygous, and the way it arches is what we saw in the lungs. It arches to drain into your superior vena cava. Your azygous has other veins that help it, like your accessory veins and your hemizygous veins, which drain into your azygous, which drains into your superior vena cava. And then we also have these nerves. So this is our sympathetic chain. It's literally this entire thing. These are sympathetic ganglions. You have greater splanchnic nerves, which are these longer ones. And then you have lesser splanchnic nerves, and there's also least splanchnic nerves, but they don't have them in here, which are like very small. These are all sympathetic. The only parasympathetic splanchnics, so parasympathetic, did I spell that right? Splanchnics are your pelvic splanchnic. The rest are all sympathetic. Okay, so we talked about the superior mediastinum. If you just kind of look at how it's separated, you can kind of see most of these structures all within here. Your anterior mediastinum, so now we're in the inferior part. So this is just superior. Superior just has one name. Inferior is the one that's separated into three. So anterior is so small because it's literally like between your heart and then like that sternal sort of border. Not much can fit here. So the only like really main thing you have is the internal thoracic artery and vein. And lab, when she literally like lifted the rib cage, you can kind of see them on the other side, so they're on the most anterior side. Other than that, all you really have is like connective tissue, fat, some lymphatic stuff in there, because not much can fit in there. And then we already said if it's an infant or a child, the thymus kind of goes down into the inferior as well. It's more prominent. In the middle is just like heart stuff. So everything we talked about, your heart, ascending aorta, pulmonary trunk. So heart, as the aorta is ascending, so not the actual arch, but just like the ascending part is in the middle mediastinum, pulmonary trunk. So pretty much just like all of your heart stuff. And then also the phrenic nerve, because that's going to go all the way down to your diaphragm. So it's going to cross your middle mediastinum as well. Posterior, if you remember dates, so your descending aorta, so this is what we saw here, descending aorta, or again thoracic aorta, your azygous and hemiazygous, the stuff we just saw that drains into your SVC, that makes sense because they're going up into your SVC, so it makes sense that they're going to be on the lower side, specifically in the back. Your thoracic duct, again, that's the thing that pierces through, goes all the way through your diaphragm and drains like more than 75% of your body. Your esophagus, which we can see right here. We also saw it in the superior mediastinum. And then your splanchnics, which you obviously can't see here, but they're going to be like on the spinal cord. Your sympathetics. Another thing that they didn't put here is also your vagus nerve. So if you remember dates, vagus, you'll remember your posterior mediastinum. I'm trying to see if I missed anything before I move on to the cranial nerves. We did the veins, the arteries, all lung stuff, heart stuff, papillary muscles, chordae tendineae. Okay, I think we did everything here. All right, now cranial nerves. So I'm gonna give you two mnemonics for the cranial nerves. They're not the best or most PG rated or whatever. It's how my human phys professor taught me in undergrad. So you're gonna learn it the same way. If you remember the acronym, let's do red, since we're doing red all day. Ooh, to touch and feel very good. You can kind of tell what that is. And then, like the sound you make when you drink like a cold Celsius. or when, okay, so ooh, 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 to touch and feel, very good, vagina, ah. That's how you're gonna remember the names. So, first one is olfactory. Second O, optic. Third O, oculomotor. Then you have T, trochlear. T, trigeminal. A, abducens. F is facial. 8 is vestibulocochlear. G is glossopharyngeal. I'm trying to write without like pressing on the mic. 10 is easy to remember because it's vagus. A is accessory, specifically spinal accessory. And then H is hypoglossal. Now, this is how you remember the names to remember which ones are sensory, motor, or both. You're gonna remember this. Oh my god, I can't write. Okay. Some say marry money, like someone with money, but my brother says big, and then we're going to keep it somewhat PG because we kind of got a little crazy with the last one, you know. Brains, obviously you can put whatever, big boobs, big butts, whatever helps you remember, matter more. So some say marry money, but my brother says big brains matter more. So you just follow the letters. So S, sensory. S, sensory. M, motor. M, motor. B, both. M, motor. Both. Sensory. Both. Motor. And motor. So that tells you what each thing does. Now, to kind of summarize what they do, I would definitely go over his PowerPoints just because I think he goes into specifics on where they travel, what they go through, which bones they're around, where they enter. So that kind of helps understand like where they could get damaged specifically. But this is kind of just like a brief breakdown. Olfactory has to do with like smell. Optic, so I'm just going to kind of summarize them, has to do with like your eyes. Oculomotor is also your eyes. Trochlear, also eyes. Trigeminal has to do with like all parts of your face. So I'm just going to keep that the way it is because it has 3 big parts. Abducens, eyes. Facial also has to do with a significant part of your face. Let's just say like face for both of these for now. Vestibulocochlear has to do with like your ears, so hearing. Glossopharyngeal has to do with like both your tongue and the back of your throat. So let's say tongue / pharynx. Vagus, that's the parasympathetic thing we talked about. That does like for your heart, it does a bunch of things too. Spinal accessory, that's the one that controls your traps and SCM, sternocleidomastoid. And then hypoglossal has to do with your tongue. So to kind of summarize a few of like the lesions and what they could do here, the ones that are just sensory are just going to affect that sense. So if you can't smell properly, like during COVID, for example, your olfactory nerve is damaged. This is just a sensory thing. If you can't see, then something around your optic nerve is damaged. So you have like a whole complicated process of like how vision works and it crosses the back of your eyes, whatever. But if you can't see the vision itself, there's a damage with your optic nerve. That's completely different than if you can't move your eye in a certain direction. Those are motor, motor, and motor. So you actually have 3 cranial nerves that do movement for the eye. So the way to remember it is this. SO4, like sulfate or whatever, LR6, R3. So superior oblique is your cranial nerve 4, which we said is your trochlear. LR6, lateral rectus, is your cranial nerve 6, which is your abducens. And then the rest are all 3. So 3, 3, 3, and 3. And these are all your oculomotor. So this right here is a right eye. So if you want to move your eye towards your nose, you're moving it medially. That's called a medial rectus muscle that pulls your eye towards the middle. If you want to look to the outside, or your right eye to your right, you look laterally. You have a lateral rectus. So you have 4 rectus muscles and 2 oblique muscles. So they actually made a mistake here because your rectus should be on the lateral side, not on the medial side. So how do we do this? Okay. Make this lateral. Oh, but this is right eye. Okay. Make this superior oblique. Make this superior rectus. Make this inferior rectus. And make this inferior oblique. So same rules apply. So superior oblique is your cranial nerve 4. Lateral rectus is still your cranial nerve 6, and everything else is 3. So 3, 3, 3, and 3. So the reason you can tell that this is wrong is your superior and lateral rectus I already have IR. So superior rectus and inferior rectus, they move your eye up and down only when it's lateral. So when your eye is lateral, so it's looking this way, then the superior lifts it up or the inferior lifts it down. With your medial rectus, when the eye is pointed inwards, it's actually flipped. Your inferior oblique is on top, and your superior oblique is on the bottom. Let me get rid of all of this because I feel like they got way too confusing. I can't believe they just post this online and it's all wrong. Okay, this is an eye. So let's do, this is your eye. Obviously this is left eye. This is right eye because this is anatomical position. So when this eye looks this way, your medial rectus lets it look inside. This eye looking this way, medial rectus. This eye looking that way, lateral rectus. This eye looking that way, lateral rectus. Now, when we're laterally, looking up is superior rectus. Looking down is inferior rectus, and then same thing here. So up, I'm going to do SR, superior rectus. And then down, I'm going to do inferior rectus. When you're looking medially, up is actually inferior oblique. So it's the opposite because of the way the eye rotates. And down is superior oblique. So I'm going to circle these with red so you can kind of see that. And then same thing on the oblique, down would be superior oblique. And then that same thing applies. So SO4, LR6, R3. So superior oblique is your trochlear nerve. Lateral rectus is your abducens nerve. And then the rest are your oculomotor nerve. So the reason this is important is this. If you have damage to your lateral rectus, so if we have damage to our lateral rectus on the left side, so let's say left lateral rectus, we have a lesion there. Your eye muscles are just like any other muscle in your body. So we have in our arm, we have flexors and extensors. When our arm is like straight, that doesn't mean that neither our flexors nor extensors are putting in any effort. That just means they're putting an equal amount of effort. The eye is the same way. When the eye is in the middle, that means all of the muscles are putting in the same amount of effort to keep it pointed in the middle. So if I damage my left lateral rectus, my eye can no longer be pulled this way. So my eye actually stays stuck like this. So this left eye is stuck down here because the left lateral, the one that would pull it sideways, doesn't work. So that's an example of like how these can get damaged. So if the eye, for example, is stuck only laterally, so if the eye, so again, this is a left eye, if it's stuck only laterally, then your lateral rectus is working. This could be like a lesion to your cranial nerve 3 or oculomotor, for example, and possibly cranial nerve 4, which causes the eye to go laterally. So whatever is damaged won't be putting in that effort, so everything else takes over. A few other ones are, so we said if you can't smell, it's olfactory. If you can't see the actual vision, it's optic. We just went over the 3, 4, and 6. If you can't hear, again, ears, sensory, it's a damage to your cranial nerve 8. With the gag reflex, so when a doctor like sticks something in your throat, you have two parts to the reflex. First, it's sense, so the sensory part, so sensing that there's something in the back of your throat, is actually cranial nerve 9 or glossopharyngeal nerve. The choking sound or whatever sound you make because something got in the back of your throat is the motor part, which is cranial nerve 10, which is your vagus nerve. So if your gag reflex is not working, then one of these nerves at least isn't working properly. Either you're not sensing that something's back there, or you're sensing it, but the motor nerve, your vagus nerve in that case, is not working, so you're not making the sound that you're supposed to make. A few other things that you can easily test are, so with spinal accessory nerve, so cranial nerve 11, if you can't shrug your shoulders, then your traps aren't working because this nerve is damaged. So on the right side, you can't shrug your shoulder, your right accessory nerve isn't working. On the left side, you can't shrug your shoulder, left spinal accessory nerve isn't working. Now, sternocleidomastoid, when you turn your head to the right, you can feel a muscle on the left side of your neck kind of bulge out because that's your sternocleidomastoid. So your left sternocleidomastoid lets you look right. So if your left sternocleidomastoid is damaged, you can't look right. So lesion, left cranial nerve 11, you can't look right because left SCM is injured or damaged or whatever. So you can still look left because your right SCM is normal, if that makes sense. Now, with the vagus and the hypoglossal nerves, they actually do the complete opposite thing. So with vagus nerve, another way to test it, so we said one of them is the gag reflex. But with the gag reflex, you can't always tell if it's the 9th or 10th nerve. So if it's the glossopharyngeal, the sensory part, or the motor part, the vagus nerve. So what you could do is you tell a patient to say ah, and the back of their throat, they have this thing that sticks out. It's called a uvula. So if it's in the middle, that means it's good. But if it deviates to one side, so you tell them to say ah, and then it looks like this, it deviated to their left side, because that's left and that's right, then that means there's a damage to the right vagus nerve. So when the vagus nerve is damaged, the uvula goes away. So uvula away from lesion. So think of the vagus nerve as something that pulls the uvula towards it. So if this is my uvula, I have my left vagus nerve and my right vagus nerve. They're both pulling it towards it. But if this is damaged, then only the left pulls it towards it. So now it looks like this. There's nothing pulling it to the other side. So that would be a right vagus nerve damage. So the uvula, it's going away from the lesion. It's going to the left side. The lesion is on the right side. This is different than the hypoglossal nerve. So the hypoglossal, so this is cranial nerve 10. This is cranial nerve 12. Hypoglossal nerve, you tell someone to stick their tongue out, this is their tongue. If it's midline, think of the hypoglossal nerve as your left hypoglossal nerve and right hypoglossal nerve. Don't think of them as like pulling so with vagus we said it's pulling it towards it. Think of hypoglossal as they push it. So if my right is damaged, then my tongue will be, when I stick it out, it's going to go to the right side. It goes, so tongue goes towards the lesion. And the uvula went away from the lesion. So think of the vagus nerve as something that pulls the uvula towards it. If the right side is damaged, then the left's going to pull it towards it. The left is normal. The hypoglossal nerve, think of it as something that pushes the tongue to the middle. So if the right is damaged, then the left is going to push it to the right, but the right can't counteract that push to keep it in the middle, so it goes towards the lesion. So hypoglossal nerve, wherever they stick their tongue out, the side they stick it towards is the bad one. So tongue goes to the right, hypoglossal nerve is bad on the right. Tongue goes to the left, hypoglossal nerve is damaged on the left. With the uvula going to the left, the uvula is damaged on the right because it's away from the lesion. Uvula going to the right is pulling it normally, the damage is on the left vagus nerve. And I think that's about it. If I remember anything, or like if they add anything on the slides, I'll make another video. But I hope this was helpful. Thank you guys.